Marking pen.
Marking.
What my into this introduction is beautifully what would you suggest? Sometimes the capsular layer is so thick that you go to get your purchase of the nose, you go the camera. You worry that you might go and if it's none, now you feel so whether it is
चेंज क्या करना है, बस तेरे को इस हिसाब से लेना है कि ये कैसे कनेक्ट करें.
Thank you, Dr. Subhash, for the wonderful talk on diagnostic approach. And now we move on to the next talk, posture approach by Dr. Ashwani.
Good morning, everybody. I think everybody is so impressed with direct approach and identity approach and the super path. So I'm going to talk about posture approach, which is going to be a little bit of repetition of the previous talk and repetition from the previous talk. And I would say the indication for posture approach would be the contraindication for direct anterior approach and the super path, which is obese patients. Okay, 90 to 95% of the people here have already done posterior approach, so I don't need to go much into details about the posterior approach of the hip. So these are different approaches to the hips, and everybody chooses the approach depending on their comfort. Number one, number two, what they want to achieve really, and what the anatomy of the hip which we are dealing with. Okay, so these already the slide has been shown before. Different approaches to the hip, and again different approaches to the hip, including super. So posterior approach basically was considered as the only legitimate approach to the hip, but now more and more legitimate approaches are coming up now. So it doesn't violate the abductors. The most important structure in the hip is the abductor, and that is what it doesn't basically violate. Arguments against the rate of posterior dislocation are very high. Evidence shows that with tendon to bone stitch, the evidence the chances of dislocation are less than 1%. Tendon to tendon stitch, the chances slightly go high to 1 to 5%, and they are higher in basically the 5 cases. But if you take these stitches properly, bone stitch or bone tendon stitch, the chances of dislocation are very low. Okay, how to reduce this? How to reduce dislocation rate? There are different ways you can reduce the dislocation rate. So that is one of the most important complications which you have to know about. Proper technique for capsular suture, most important. Tendon to bone stitch rather than tendon to bone stitch. Abduction below, most operatively, very important. You have to drill in patient's mind. This is what you have to do at least for first 6 weeks. Below between the legs when sleeping on the normal side. So this is again important thing. Everybody must have thought it on the wall. But when you are sleeping on the non-operated side, you have to take the pillow in between, and when you are sleeping on the operated side, you don't have to take the pillow because you don't cross the legs. So avoid shoe time position, that is flexion, adduction, and derivation. These are the things which you have to drill in patient's mind. Keep long knee brace in non-compliant patients or basically in those patients. Tips for closure, basically use orthopod, fiberwire or AC bond, and take a stitch in the acetabulum, bone stitch, or you can use the anchor while tying the capsule, or few of the patients what they are doing is they are taking those stitches on the basically acetabular shell, and then put the acetabular shell and take those stitches and then stitch the capsule. So these are few of the tips which are there for closure. Rana stitch, very important. That is tendon to bone stitch. You connect all the extra rotators which you cut to the bone. Few of the bones are soft, few of the bones are hard. So if the bone is hard, you just drill it with the wire and take the stitch properly. But it has to be tendon to bone stitch, not tendon to tendon stitch. Okay? You don't take the sleeve of tendon and take the stitch from the tendon to tendon. Take a bone stitch. So that's what reduces the chance of dislocation. So posterior approach basically the implication is basically to reach the posterior wall of the acetabulum. If there is implant in the posterior wall of the acetabulum, and if you want to remove it or if you want to tackle the posterior wall of the acetabulum along with the total hip replacement, then this is the approach which you take. These pictures you have already seen. So we'll skip these pictures. One of the important things again I would like to highlight is sooner or later hip resurfacing is going to come, and that is the time when posterior approach will be very, very important. And in addition to the normal releases which we do in posterior approach, one of the important release is basically you release the distal part of the gluteus maximus tendon from its attachment. So that's what gives you the best exposure of the hip after doing posterior dislocation. So that is one thing which you have to remember if you are doing resurfacing in future. Again, the capsule forming, these are the things which you have already shown. Orientation, which is the most important thing in all the hip approaches. The most important thing is in orientation is basically you have to see the lesser trochanter, you have to see the intercondylar line, and that is the angle which you have to look for to get the anteversion of the hip. Okay, so these are the few of the tips which you have to remember. Thank you.
One question.
989900. Sanjay. 9900. ਤੁਸੀਂ ਜਿਹੜੀ 00 ਹੈ ਨਾ ਉੱਤੇ ਥੱਲੇ ਕਰਦੀ ਹੈ ਆਟੋ ਬਣਾਤਾ
I mean, either metal or metal will again come with another technology, metal technology, or something or the other is going to happen in this technologies. And this is the approach basically familiar with, and other than posterior approach, I have seen only anterolectal approach. Have you seen any other approach for the
Yeah, because we did about
yeah.
I used to do the cancer for the research.
Yeah, interlateral approach I have seen for
Okay, can you elaborate on the suture and the required in the acetabulum for suturing?
basically the suturing of the capsule is most important step in this posterior approach. So that is the thing which can cause dislocation. So if you use the suture anchors in the acetabulum to create the acetabular end, that will be what you purchase, and you can take the sutures in the capsule if you don't have sufficient soft tissue to suture it to. Sorry?
You need to put those sutures into the femur.
No, in the capsule. In the acetabulum capsule. Acetabulum to capsule.
Thank you, sir, for the wonderful talk. And now we'll move on to the next talk, the last talk of the first session, that is pre-op planning and templating by Dr. Neeraj Prasad.
Natural interest. Just want to show hands for people doing the posterior approach. Anterolateral approach, the hardest. Direct anterior. Look it down. Anyone up there? And super path.
Before we let you go on this, because you are there on the expert table.
how much of a, and this is directly to each of the individual that the patient is being asked, how much do you give value to the approaches like the super path or even I would say direct anterior, because they are associated with the both skill, clinical and technical challenges. Do they offer enough value, clinical value for the for making it into a standard of care type of a surgical approach for the vast majority, or are we just turning this into an aspirational statement so that an entire generation of young surgeons, irrespective of their skills, and let's be honest, not each one of us can be a nurturer. So an entire generation of surgeons are being
सर की आईडी खोल लो, सर की यूट्यूब पे आ जाओ, यूट्यूब पे
relatively difficult and technically
यूट्यूब पर आ जाओ, यूट्यूब
do
पर
they offer any
सर
real
की आईडी
value
पे
in your opinion?
सर की आईडी पे यूट्यूब पर आ जाओ.
Most speakers will agree that ultimately it doesn't matter. I think you are
लाइव सर की आईडी पे यूट्यूब लाइव आ रही है, लाइव सर की आईडी पे यूट्यूब पे उसमें देख लो.
super confident in doing hip replacements. Big out of block, perhaps they could.
सर की आईडी पे देख लो, सर की आईडी पे यूट्यूब पे.
Definitely, there is a preservation of soft tissue with early
सर की आईडी पे देख लो यूट्यूब पर लाइव.
So I would say you are in case, I think there are advantages, very advantages. You always have
So to sum up, because not each one of you will be able to afford Dr. Rajesh Malhotra coming to you for so do not allow aspirational height.
लैपटॉप पे खोलो, लैपटॉप पे यूट्यूब सर का
Doing something which can be
इस पे दिख जाएगा.
all the standard posterior or a hardened approach deliver consistently good results. They are time tested. They are generous in terms of being able to accommodate a little less than the Arjun's eye, and yet you'll be able to be a good and predictable surgeon. That's the message I want to let you out here as a course director here, and I'm sure Rajesh might have some. I'll digress a little bit here and maybe disagree a little. So first thing is that, like Uday said, all approaches are by and large same. So there is no objective evidence that one approach is better. That's the one. Totally agree. Number two is that you should actually try to be a circumstantial with surgery. Why do so many can there are people who are doing anterolateral, they come to the insect, show me how the direct treatment is, so that I can think of it. So, have a learning. That is number three, identify when we said that it is hazardous because there is enough evidence to say that if you learn hip replacement by direct treatment, the learning curve is much shorter. The whole issue here is that you learn something, say for example, by posterior approach, and you have to unlearn and relearn because your orientation is right. The patient is in a different position, he is not lateral, he is supine, how you adjust the version, how you adjust the abduction, well, everything changes. But there is enough evidence that the learning curve is very short, the complication rate is less. If you are trained, so if you don't know how to do a hip replacement, and I said two groups of people, one to a posterior approach surgeon, one to him, and one to me to teach them hip replacement, and he teaches the anterior we teach them posterior and I teach them direct. There's not much of a learning curve. The problem is both unlearning and relearning. And about, I think it's very important that we address every approach has a role. For example, if somebody has done an anterolateral approach and hip is infected, I have to take it out. I'll take my anterolateral approach and not violate the posterior vein. The chances are that the clean the line of detection will be infected. I will take out that if I have one anterolateral approach. Why do we take posterior approach? I will not go by direct anterior I got to. One of my first cases was a septic arthritis of childhood, operated from the front
flexion deformity of 30 degrees and scarring on the entire for the leg. That requires extensive this was just when I all the conditions. So the important thing is try to be a circumcision which will be number one. They again coming back to where I will do only directed period, where if I have only into this. Neck of fever pain, I see clavicle pain, I see all kinds of fractures that we will try to position them in a you can have imaging right there, you can put the right side up at the right depth, at the right level, particularly in the cases in a very odd position. The second thing which was mentioned, we doing bilateral hits is a big advantage that saves so much of time. And you can just do it in a right position for choosing over equilibrium and bilateral. And of course, the advantage of cosmetic intervention for young ladies, vertical incision is possible to use the directly.
I just synopsis. There's no disagreement, to be honest, from what Rajesh is saying and from what I have just conveyed. What Rajesh is saying is that as you go along in your path of becoming an orthoplastic surgeon over the next 20, 30 years of your activity, learn all the different approaches around it if you are going to be a comprehensive hip surgeon. And nobody would disagree with that. My message is not in conflict with what Rajesh says. My message is, I see this day in and day out, that entire generation of young surgeons are pressurized to take on certain surgical actions purely from the peer pressure created through these sort of courses where the direct entry is supposed to be the hip thing, unintended to do. You know? And in doing so, they might be risking themselves. So do it at the time when you're genuinely understanding how you do a simple posterior or lateral approach, then go on to these things.
होने वाला थोड़ा सा सब रेडी है बस होने वाला
Good afternoon, everyone. Thanks, Nidal, for giving me this opportunity. So I think irrespective of the approaches and everything, what is the most crucial and important thing is pre-operative planning and templating. And I think all of us will agree that it requires good planning and templating before we execute our surgery. Because many times if you don't do that and say post-op X-ray, then we are, oh, we should have done this, we should have done that. It is important to examine the patient, take proper history, do proper templating, so that you can reproduce your surgery, reproduce your offset at the time of surgery, and probably the post-op X-ray and function of the treatment will do. So when we talk of preoperative planning, the most why we are doing planning, because we want to restore the hip to its mechanics. We want to anticipate what are difficulties or pitfalls we can arrive at the time of surgery, and obviously reduce the risk of complications. So when we are talking about planning, what should be the steps? The first most important step is history taking, examination. Always take weight bearing or maybe supine standardized X-rays. You should know what a good pelvis epic looks like. Assess the patient for fitness. Template the radiograph, and then you can select your implant choice, your approach, and the type of implants you want to use. So when we talk of history taking, most of the conflict arises when the patient has dual pathology. Let's say an elderly patient has some pathology like lumbar gynecomastia, also has hip arthritis. To get proper history taking into MRI scan to rule out the spine pathology, so that after surgery it's not happening that the pain doesn't go away. Always take history for previous minor surgeries, because if there are spine fusions or previous hip surgeries or long segment fusion for the spine, the pelvis may be tilted anterior posteriorly, and you change your abduction angle and anteversion accordingly. Always take what all medications patient on, rheumatoid patients, substituents they are taking, steroids they are taking, talk to your rheumatology colleague so that you can stop it before surgery, and then subsequently you are started. Always discuss what are the demands and expectations of the patient. This is the era total hip replacement we do in young patients. Maybe if you are not discussed enough with the patient and post-operative with the patient, may completely cut off complaints. Then comes the part of examination. Always examine, always remove the shirt and pant. I have faced myself, I have not examined the patient properly. I admitted the patient has a further injection, patient again has to go back home and come back after 10 minutes. always remove everything, examine the local skin conditions, especially for previous scars or fungal infections, assess the deformity. Many times we are doing young patients, they may have adduction or adduction contractures, they may have flexion contractures, obviously they will have some limb length discrepancy. Check the BMI of the patient and always check the gait of the patient. Sometimes the gait of the patient may be quite different. You will come to know whether the patient has his spine, maybe have pelvis tilted anteriorly or posteriorly. A lot of things can be get through this. Now, next step comes the investigations, and for us, the most important investigation is to get a good X-ray. So, let's say we are doing a bed bearing pelvis AP X-ray. First point is to square the pelvis, make the leg in 15 degrees of interrotation, and the X-ray tube should be projected at the symphysis pubis so that the pelvis and the upper third of the femur is covered. Lateral, we can take lateral view or longitudinal view. Usually, we don't take cross-sectional lateral view. But if the patient has maybe abduction or adduction deformity, most commonly the long-stem lateral view what you take. Now, how will know whether the standing hip X-ray is suitable for templating or not? It is suitable only when most of the landmarks which you want to know are seen on the X-ray or not. Most important is the size and the shape of the obturator foramen. Your sacropoccygeal line should pass to the center of the symphysis pubis. You'll be able to see a teardrop. You'll be able to see Fowler's line. Maybe root zuculateral part of the acetabulum, adult, greater trochanter, lesser trochanter. Now, it depends on the X-ray projection how much of the lesser trochanter is seen. If your leg is not in 15 degrees of interrotation, then probably the leg is in external, then the lesser trochanter, more part of lesser trochanter is seen. So ideally, if less than 3 to 5 millimeters of lesser trochanter is seen, that means the pelvis AP X-ray is good. Once all these landmarks are easily identifiable, then yes, we can say now we can template on these AP X-ray. As I said, you should always calculate the distance between the sacropoccygeal joints of the symphysis pubis. Average distance is around 32 millimeters in women and 47 in men. If, let's say, ankylosing spondylitis patient or previous spine surgery, the distance may increase if the pelvis is treated anteriorly or it may decrease if the pelvis is treated posteriorly. Accordingly, you have to change your abduction and version. Now, the first part of templating, we should know what are the references you are taking. So, a horizontal reference usually we take at the teardrop line. Second, we should know what
Yes,
is
sir.
the center of
हो गया, डन हो गया.
and then we should know the horizontal offset and the horizontal offset starts in the center of the hip to the tip of the retrocenter. And the acicular offset starts in the center of the hip to the teardrop line. And then we have a combined offset combining the two. The X-ray will also tell you the limb length discrepancy, what the patient has and what we have clinically measured. Now, as I said, the templating part also starts, usually we do the acetabulum part first and the femur part second. So the templating will start from the acetabulum first and then the femur part. So when we are doing the templating, what we should know, what will be the size of the implant, what will be the position, insertion depth, and what if there are any potential complications or difficulties we can arise at the time of surgery. So when we are templating the acetabulum, what three things we should take into consideration is the depth, medial-lateral positioning, superior-inferior positioning, and yes, the attraction of the inclination angle. So when you are starting with the acetabulum, you have to mark 3 points. The horizontal reference point which you have drawn at the teardrop, you have to mark 1 point on that reference line. Other point marker should be on the ileoischial or the Fowler's line, and the third marker should be on the superlateral or column of the acetabulum. Your template should be touching all the 3 points simultaneously with deep abduction across 45 degrees. When you are doing this templating, mark the center of rotation. Also mark down if there are any osteophytes or you can see any visible cysts. Record it on the paper. Now, as we know that acetabulum comes in,
सर वाले में
you may have different problems with
वो
acetabulum.
मेरा नहीं YouTube.
YouTube. Patients, maybe osteoporotic the patients. And to restore the anatomical center of lip, one should remember that you have to lateralize the template, lateralize to the eardrum of the coronal line. Always measure the defect of the medial bone block because you need to reconstruct with the bone grafting there. Sometimes the accident may be lateralized, especially in primary and hypertrophic osteoarthritis because of weak medial
presentation इनके बाद है ना?
lateralized. In such cases, if we have not templated preoperatively, then we don't know how much to read medially. Many times we can measure the distance from the floor of the acetabulum. I usually drill and usually make a drill and measure how much is the distance so that I am sure that I am on the floor of the acetabulum. And then we can always mark that whatever osteophytes are there, inferiorly, medially, or superiorly. This is a special case, dysplastic acetabulum. We always take an echo CT scan to understand how much is the stress of the entire posterior wall. Because sometimes they get migrated, they will get down. But medially, and obviously when the superior part is unsupported or uncovered, it is a big thing. If the proportion is big, then you need to go up, then you can measure the operation of the template, and then in the operation you can always ensure that the same is there. Now comes the femur part. Now the aim is to choose an implant that will restore our femoral offset, that is the horizontal femoral offset and the horizontal offset. The femoral skin should have an optimal point posteriorly, and we should be able to adjust the offset. These templating may not work well if the patient has got very bad coxa valva. So just taking an example is, let's say the patient has got a primary arthritis in the hip with a shortening of 1 centimeter, then what we should do is we should take a appropriate size of the femoral template, mark the center of rotation of the femoral head. Now let's say we want to lengthen, then you mark, you have to have 4 measurements. One is the horizontal offset, vertical offset, that starts from the vertical offset starts from the proximal point of the lesser trochanter, horizontal from the tip of greater trochanter. You have to measure the distance of the neck osteotomy from the lesser trochanter. Once you have all these measurements, record it down, because all these things we can measure intraoperatively and check whether it is matching or not. Yeah. So as I said, this should be a templating notes. At the end of your templating, you should know the size. You should mark down the cyst osteophytes on the femur side. You should know the same size, and this score recording should be there. Horizontal offset, vertical, neck cut distance from LT and distance between the neck cut and stem. As I said, the most important part is surgical scenario will not always match the preoperative plan. For example, the cup of the stem may be of different diameter. Accordingly, you have to modify your center of rotation and limb length. And most important is the tactile feedback what you get during broaching and rimming. That because that provides the important you to select the size of the implant. And yes, by failing to prepare, you are prepared to fail. So always plan and do your templating before doing a total assessment. Thank you.
Thank you, sir. So now I call upon the post directors, Dr. Rajesh Malhotra sir and Dr. Bharat Modi sir on the dais for a small felicitation program. And for this felicitation program, I would like to call Manish Deshmukh, Rajesh Pandey, Shivaneshan, KP Rajesh, and Nadeem from Merrill Academy.
ऑडियो मैंने खोल दिया है सर, भी जब बोलेंगे तो फिर हो जाएगा. ओके सर को बोलना एक बार ऑडियो टेस्ट कर लेंगे. हेलो सर को आ रही ऑडियो आई थी.
Thank you. So, sorry, we don't have time for tea break. We can do a working tea break. You can just get your cup of tea and again get back to the hall. But now, before that, we go for the live surgery too, which is the Libertas Ceramic on Poly by Dr. Ashwani Maichand, K Birla Hospital, New Delhi. Hello, sir. So, are you able to hear us? You're live now.
Okay, hi. So we started from good morning and now we are in good afternoon. Good afternoon, everyone.
I'd like to call Dr. Avinash, Dr. Ravi Shauta, and Dr. Chandrasekhar to moderate this session.
Good afternoon, everyone. So shall we start? I'll just introduce you to the patient. This is a 47-year-old gentleman with AVN stage 3. We are operating left side and it is a classical old, or I would say rather boring posterior approach. So shall we start? Hello.
Yes, sir, you can start. You can start.
Okay. So we are making the slightly more for the camera. This patient is having AV on both sides, but right now, this time he is planning only for left side because right side is comparatively pain-free.
This is Dr. Bharat Modi here, and we'll be interacting before teaching us here. So which approach are you using?
Posterior approach.
Posterior approach, yeah. And because there will be a varying grades of surgeons sitting in the audience.
Yes,
so
yes.
Would help us to understand how you have chosen the length of your.
Recording in progress.
The length from here seems quite compact. So, is this an intentional thing, or do you think that in here it would not be required to do anything more than this?
I think with time I have started reducing the length of the incision. It's the standard classical incision of 45 degree, keeping the base of the trochanter in center. Chandler?
Can you please orient us as to the positioning of the patient?
Okay, fine. I'll just do that. Give me a minute. So, this is the head and foot end, and we are starting around 45 degree on the long axis. This is the base of the trochanter in the center. So I heard a lot about DA. I was listening to all the discussion. It was really interesting. But I don't know personally how useful the DA is going to be, especially for people who are just entering orthoplasty. Because many of our listeners delegates are young surgeons. So I think the discussion was really good. Talking about just telling some good things about it. But we are still on the posterior approach, and I think it's easy because we have been doing it for so many years. Maybe that is the reason. Artery please. This is the general renowned leader always there that when you remove this fat to see rotators. So you have to be careful about these leaders, otherwise the massive surgery really messy. Number one.
Can you tell us which muscle are you going to?
Okay. Let me tell you. So right from piriform is lamellae, internus, and this is quadratus that I take down at the end. So these are the data that I am taking in my number one suture so that I can repair them at the end of it.
Files have on this one, okay?
Yes, sir, please.
Where have you put your body?
This is just, sorry, this is just under the rotator, it's the inferior humen, under the inferior neck, and this is just above the piriformis.
So both on the neck. One is on the top
Yeah,
end of
inferior neck, this is superior to the neck, just between the piriformis and minimus. So I'll try to take it down as close to the bone as possible so that I can get the maximum length and I'm repairing it. So I'll make a T of the capsule, taking it down from the center and vertical limb going right up to the labrum.
We are not able to see the properly.
Camera.
And the camera sees it.
Exactly by it. They're not able to see it. Are you able to see it now?
yes, it's correct. Yes.
Learn sharp. So it's normally it's not vulgoid. It's around, so we are it's around 135 degrees. So I'm taking the standard one finger back from the left of the center. 45 degrees.
You know, the other thing you can
That's good.
that whilst every comprehensive course will have one chapter on templating, the reality of that all those lines that you draw on your X-rays or on your template, I don't think they can be really translated and those minutes on template. And I would recommend it. If you ask me why do that, maybe
So it's a big head, and you can see there's a collapse there. You see that?
and it's probably
Footstool.
but spend those calculating minutes because it offers your mind the ability to focus on the case not necessarily translating those points into the probability scenario. So it will have made you aware about things that what the depth and what of the procedure or some of the wise calculating.
Right.
In a practical sense, you are not contributing to the operating.
Another interesting thing is basically in the olden days, people used to keep that head into soft tissues for the future use. They want to. Anybody is doing it? Actually?
Even leave it behind.
Leave it in the gluteal region in the soft
Post
tissue.
op as well.
Yeah.
Oh, notified dramatic disease, or unless you take a very specific order to inform consent, your good intentions might backfire. Right?
Patel bhai,
One thing that almost talking about the everybody's explained the points and templates. Unfortunately, it is hard to have but now digital is available, but I don't know how many people have access to digital templates. How many? Hardly any. So how expensive.
So the problem is, in fact, we ran overtime that meeting later. But one of the problems with calculating these days is we do not know whether it is truly representative of the size of the patient's anatomy. So yes, as I said, for me, in a realistic sense, templating helps in focusing my mind on that case on that day. You know, I wouldn't take those millimeter measurements as gospel truth when I'm actually going through the picture. But yeah, coming back to our
talking of that bone that you were talking of, keeping that bone in this thing, Dr. Suresh Venkar did all these years and used to fix the bone into the iliac crest with a screw. And believe me, those patients coming for revision now, that bone is so helpful, it remains there. You can take out the screw, take out that big, huge femoral and then use it for your graft as actual patient's own graft, and it works very, very well.
Especially if the patient is
I agree with what Bharat Bhai is saying that it is, of course, today legality is different, but those days are always, I used to see it all the time, and that bone helped us after so many years into this.
This has been described, so this was like in situ bone bank, and this is really been described as a very useful thing. But one thing about what Dr. Bharat also said, while the templating is important, like they said, how the digital templating is a top. I think the best thing is what we normally do, which I do less in direct engineering, so it's possible. Intraoperative templating, which is you dislocate the head, measure the vertical offset, horizontal offset, and recreate that. So take out the head, measure it, and hold the side. So that's how it is. So if you don't dislocate and do the measurement, also this is one way, although you are going minimally invasive, but you are missing one, what we need to do is present templating and then restore them.
Ashwani,
Yes, sir, please.
when you are reading, at least here, as the picture is being transmitted to us, it would appear that you are doing a slightly rotatory movement of that reamer.
Yes.
And may I ask you, would that not perhaps risk a mismatch in the sense that, if the reamers are supposed to be absolutely congruent to the shape of your implant cup, why are you doing a slight amount of rotation that I saw?
I do it just like the painting on the wall. I take the cartilage all around, and it doesn't matter. My trial implant you see will fit perfectly well. So I try to take all the cartilage around, because if I keep it stable in one direction, I leave margin of cartilage in some areas, which I don't want.
Okay, fair enough. No, I take your point. Based on your experience, I'm sure you have because you have been doing it and you are so experienced, you have your way of ensuring that
I think with time you develop your own way of.
Yes, you're right. But in general, I would like to point out that when you do a rotatory movement of your acetabulum, it might be a small definitive risk of changing the shape of your recipient bed of your acetabulum.
Rather, I feel it that way that if I don't rotate it, I'll have a margin of cartilage all around, and fitting of the trial and implant will be difficult for me.
Yeah, so firstly on the bone of that point. And the reason for that, and you will find that almost all hip systems have this problem as far as the reamers are concerned. And you know why? I worked that out only about 3-4 months back. It's to do with the manufacturing process of the reamer. If you look at the reamer, the thickness of the metal sheet from which it is stamped out, to ensure that the edge of the reamer doesn't undergo fatigue fracture, they have to start their scouring cups, this was what the children wala.
फ्रेम हल्का सा इधर होना
We have
चाहिए
to start it about 5 millimeters from the edge of
अब नीचे जो है
metallic shell. And that is why you will always have a ring of hyaline cartilages left behind, which during the implant trials as well as final fitting, and that's why you have to do what is known as mouth opening with one side higher remark. And I was used to scratch my head that with technology being available so much, why is it that it's probably done? It's only when I asked someone who was manufacturing reamers, and that's when he pointed out to me that this is the reason why they cannot bring the power right onto the edge of a reamer.
So we have to find our way around it.
Yeah.
Next, please. Section.
What size have you reached now?
It's now 57.
Yeah. With the difference.
It's quite a hard one. These are common, hard working man, strong bones.
So Ashwani, is Libertas, you are putting a Libertas system here, right?
Yeah.
What is the sectoral profile of this cup?
I don't know those details actually. Sorry.
Okay, I'll ask someone. Is it, where is the industry people here can tell me? Is it a 160 degree? Is it a 180 degree?
45 to start with.
One. So for the audience here, Libertas is the cup that Merrill offers. It's a 180 degree. And why am I bringing this up? You all should be aware that there are cup systems available which are a smaller sectoral profile. Which means, for example, the Duralock offered by another company is no more on the market now. But that was a 160 degree cup.
It's not perfect hemisphere.
Yeah, this is a perfect hemisphere, 180 degree cup. And these sort of small appreciations of the different geometrical profile of your implants is very important if you are going to be a consistent hip surgeon and a comprehensive one. These small things will make a difference about whether the lower edge of your cup should be matching with the level of the teardrop or would it be standing away from it. If you are not aware of that factor and you are only aware of the fact that teardrop ke saath match karna hai, so you will end up leaving your cup too open. So the point I am driving here is, ये तो खाली एक छोटा सा point लाया सामने से, but I would recommend sit down with the industry guys, sit down with a technical monograph that every industry offers, go through what those technical specifications of the implant systems are. If you are going to, in hips, it's even more important than in the knees. Because in hips, you have a huge range of different geometrical approaches, and spend a lot of time, not only on how to cut your tissues, but to understand the material science, the geometry science. All of these are important if you want to become a really authoritative hip surgeon. Next. Okay, sir. In fact, Uday has brought this beautiful point home. You know the metal on metal, which turned out to be a disaster in terms of the ASR, the system that Johnson & Johnson had introduced. The main reason for that system failing, it beautifully in the laboratory, but it failed in the real life situation because it was a very small, it was like a Jewish cap, that the cup side of the ASR story. And in that sort of a small sector cup, if your inclination is not perfect, let aside good, perfect, then you end up doing edge loading. In a hemisphere, you have much more forgiving sort of thing. The smaller the sector, the more precise your inclination of the cup has to be. Otherwise, you will end up doing edge loading, and the edge loading is what destroyed the ASR. Because the entire ASR philosophy of lubrication was based on not having edge loading. Only then would it have a film of synovial fluid captured within the psychological surface and giving the lubrication required. So Uday's point is making a superb case in point why you should know your geometry of your implant.
Wash your
Beautifully rimmed, Ashwani, we can see the cup in the bed quite well from here.
So we are on the breathing bone, and that is the depth of the limb now.
So if I have to ask you intraoperatively, see in the posterior approach, obviously, do you ever use IITV to see the positioning of your reamers or the depth of reaming?
What sir? Come again?
Do you ever use image intensifier?
No, never.
No.
Never.
Good. So, by the way, I do it regularly.
Actually, that is one thing that I don't like about DA, that you have to use serum to be perfect. On this side, I don't know why you need it image intensifier.
No, I agree with you. It's all about being familiar and comfortable. And obviously, at your level of now expertise, it's a good, you don't need it. May I ask you, and some of these questions are based, are being asked so that the audience, there will be members here who will find those very useful information. So how do you decide whether you have reached the appropriate depth or are not going beyond safe limits?
I'll just show you. And once you reach the depth, you can see that whitish membrane there. You can see that area. Once you reach there, that means you are next to tear block.
So would you say that what is known as the quadrilateral plate,
Yes.
which is the smooth area seen within the horseshoe, that is your Lakshman Rekha. Once you have done your breathing,
Correct.
the remaining bleeding bone becomes flush
Yes.
with the quadrilateral plate.
Then your left leg has to stop.
Yeah. So that's the practical point. Have you already implanted the actual cup?
This is the actual cup that I am implanting.
Now, just now.
Yes.
Would you be using screws to fix it?
Sorry?
Would you be using?
It's very tightly fitting. You can see how hard the membrane is.
Ashwani,
Yes, sir.
can I ask you, did you use a cup introducer or did you?
I don't.
Or you put the cup freehand and then tap it with that
Yes, sir.
and swing.
Yes.
You tap it. So every surgeon develops his own method. A classical way of introducing a cup would be with an introducer.
Because that restricts my angle actually. I can really fine tune my version and
Now, there is something that I would like to bring home. I use the Marine hip system, the Libertas and the Latitude, etc. There's one thing that I would like to bring home to the audience here, and Ashwani, you might be able to sort of give me your input as an experienced Libertas user. Do you think that you require to open up the? I saw you reading the way you did, but do you otherwise think that their trial cup and their actual cup have got a slight difference in the?
slight difference, yes. About, I would say half a millimeter.
For everyone to appreciate that their trial cup and their actual cup, the actual cup has got a porous coating, the uncemented part of the coating on it, and that's about 1.2 or 1.8 millimeter thicker. And in unforgiving bone, you will suddenly find that your trial cup was doing superbly, and when you start trying to put the actual cup in, it doesn't sink in at all. And instead of, and what I have learned is, and this is what I mean by knowing your implant system. It's a beautiful system, but I found myself not sweating once I understood this. And I went back to the company people. I insisted that I want to know, not just the foot soldier who comes to help you in the operation theatre, but going back to the headquarters. And I actually got the measurements worked out, and I got this feedback that, Doc, you are right. Our coated cup has got almost approaching to 1.8 or something, which is quite a bit of thickness, yeah, when you talk about precision especially in hard bone. So now what I do is, I do my trialing, and then before putting the actual cup, I do a mount reaming with 1 millimeter larger reamer and bob your anchor. Now it's reading superb, because as such that porosity coating is quite, it's like gription, it grips the bone.
And actually, sir, that is the reason that you should stick to one system. That makes your life much easier. If you keep on changing the implant, then you have to have sometimes you have difficulties because different companies, different coatings.
I
It
agree.
saves your time.
Absolutely. I would agree with you on that. Yeah. So, there's a question from the audience.
Sir, please.
Yeah. Yeah. You have a question.
Sir, I have a basic question, sir. I would like to know, sir, please enlighten us, where exactly the anterior pin and the posterior pin placed, the depth of the pin insertion, and any other tips regarding that.
Wonderful. So, you had put those Charnley pins in position, Ashwani, as part of your exposure method. And the audience, there's a member in the audience who would like to know where is the exact placement of those pins that you put.
It's at 12 o'clock and at 3 o'clock. Pins are at 12 and 3. And depth, of course, it should be like nicely holding. They should not be loose, and it should not be rendering your vesicle anywhere. Charlie.
So, it's at 12 o'clock and 3 o'clock position.
Yes, sir. Yes.
Yeah. Okay. For left. Yeah.
For the left, yes.
12 and 9 for the right.
Yes, yes, correct.
Okay. Who else please?
So, Ashwani,
Yes,
is there a practical tip for us to take home from your side as to when would you put the screws and when you would not? Is it just, how do you get that assessment on table that your primary fixation of the cup is so good that you won't put a screw in?
It's more, I would say, the feel basically. And when you are hitting on the edge of the cup with your punch and it's not moving at all with a good solid punch, that means it's fixed properly. If it is still moving, that means you need to put some screws there.
Have you had any objection with the movement of the cup later on post-operatively?
Very rarely. I had some angle change, cup became vertical. Very rarely. But I think that's how you learn.
Absolutely, I agree with you. In fact, in my early days of hip surgery, for a very long time in my career, I was an exclusive knee surgeon. It's only in the last, a few years, maybe 10 years now, that I started doing hip surgery. And these days, because I have other people who do knees, in fact, I am the main hip surgeon of my platform. In my very early days, I did end up finding that my cups looked alarmingly vertical as compared to what I would have thought they were on table itself. And that is why I would recommend, I don't know how you would do it from a posterior approach, positioning of the patient, although I'm sure it can be done. But in my anterolateral, it's so easy to have an image intensifier just brought in just for those 30 seconds, 40 seconds, and then once you become familiar, from your introducer or your beam angle handle, how much you need to bring it into that aided action to ensure that you don't end up suddenly finding the cup to be a bit vertical as compared to what you thought it was intraoperative.
Number 5.
One is, if in doubt, put the screws. And number 3, if you are really dealing with that bone, then try to use the multi-use cup and put a kick test which is interiorly either in the pubis or in the ischium, because otherwise your cup will have a plastic failure, it will come off. Some use inflammatory arthritis, try to put the screws at least. I do get away, but that's because when I know that my cup has such fantastic coating that it will not move. But generally, inflammatory arthritis, put in the screws, protrusio, anything more than grade 1, put in the screws, any time there is a compromise, vestibular bone, put a screw, there's no change in the screw, make sure. And also remember, if mentioned the change in position of the cup, change in position of the cup can occur even during screw placement if your cup is not very stable. So remember, if you are already in antiversion and your cup is not very snug, you put anterior screws, antiversion will increase. You put the superior screw, the cup will become vertical. You are a little bit retroverted, the cup will get more retroverted. So do this intelligently, as it was said in fracture neck keyword. If your reduction is slightly varus, use the top screw first. Right? If it is a little varus, use the bottom screw first. So if you think that it is a slightly increased anticoagulation and the cup is not as snug as you would like it to be, don't put the anterior screw first, put the posterior screw first. Right? And be sure that you are putting your screws in the safe zone. That's very important.
Ashwani, yes, I see that your first trial reduction, and correct me if I'm wrong here, because you have been having this very nice interactive discussions here, so I might have missed out. But did you do your first trial reduction after putting the actual stem in, or did you try
after putting the actual stem?
May I ask, would you recommend that to be a standard way of moving on?
No, ideally you should do it on broach, but again, it's a matter of experience and feel that now I can do it on stem directly.
Fair enough. But remember, not every one of us have Ashwani's feel. So always do your trial reductions appropriately.
One question for Dr. Malhotra. He has such a vast experience. We are talking about safe zone of screws, but many times I find that putting anterior screws is we feel more safe while putting anterior screws as far as hold is concerned. I don't know, means antro superior screws. What is his case? I just want to.
When you put anterior screws, you are much more likely to go out anteriorly. I would suggest that always initially, if you are a surgeon who just started, keep a pelvis model. The best is towards the sciatic muscle. That's what you want to target. You get good long 35, 40, 45 and just try to recapitulate your anatomy and where the sciatic muscle. That's what it is. More often than not, you have the screws which have gone out to the iliac line and they are actually somewhere anterior. And I have done so many revisions and I have seen the screws being dangerously close to the iliac artery, dangerously close to the nerve. So I think it's very good idea that before, next time when you want to do a hip, even if you have done 500 hips, have a model of the pelvis, put it on the side and see where the chassis butters and try to go, right? And then do try to, with a depth gauge, see that's what we screw, because more often than not you will find that you get a very good feel for the screw.
So we have checked in full extension and reduction is all stable. Telescope.
So I have a question to ask Rajesh. I think sometimes some of the surgeons being too aggressive about the screw length. Actually, when you use screws in this situation, in terms of using it to actually, I don't think there is any need to keep on putting very long screws. If you have got a reasonable bone stock, 20 to 25 mm screws, that gives you the anti-rotational thing. Otherwise, it's a compressive scenario that you have in a hip.
So that's an excellent observation. So the fifth era, we have the small size female or a small pelvis, and you are getting 44, 46. size cup, it's very unlikely that you'll get a 40 millimeters. Be out that you have not realized it. In a small pelvis, small cup, be very sure that you are not putting a very long screw. I totally agree with Dr. Bharat that you don't have to put always 40 millimeter screw. You'll possibly get them only in a very big person. 58 millimeter cup, that kind of pelvis may take a very long screw. And second thing is that the feel is extremely important. You know, when you are tightening the screw, where the final tightening is there or not, and if you don't get the final tightening, take out that screw. There's no point. That screw is not going to do anything. And lastly, try to get them diverted. Basically, our says that if they are parallel, they are much more likely to pull out. If they are diverted, they are less likely to. But that's not an issue. Main thing is, if your cup is hanging on to the screw, then you need multiple screws, and then you need definitely multi-directional, multi-hole, and definitely the fixed screw in the interior part. Otherwise, your cup will go.
It's a very important point. In fact, I've had this failure in my own cases earlier on. That I say, if you have a vertically oriented cup, and if you think you have put two screws and they will do your job, you're wrong. It will hinge. Your cup can hinge like this, you know. And one of the things with the Libertas cup all of you need to appreciate is that they have their screw holes in a line instead of in a triangle. So it's a line attachment. And when you have a line attachment, and if your primary fixation is very poor and your cup is vertically oriented, then despite your screws, you can have a cup hinge like this off from the lower half of it. So what Rajesh is saying is very important. You could have an option for multi-hole cup on table. If it's very soft foam, you will be so much more secure if you put the screws in different directions, which means the inferior side, let me say, the superior side, and then your fixation is very secure. There is a question from the audience.
Yes, as Dr. Bhuna sir said earlier, regarding that extended capsule refill that he mentioned. So I guess that Dr. Patel is also doing something like that. He has done this.
Actually,
Yes, sir. Yeah. Actually, how do you close your capsule and short rotator?
Capsule I have already closed, and now I'm making another layer which I will add into the home.
So do you use any anchor sutures?
No. I have drilled 2 holes in the investor seat, and I have taken through it. So it will be like your tendon to the bone.
So does that answer your question?
Yes, sir, I think. And another thing, you haven't got the pyrifol, sir?
Yes, I'm sure. He takes in all the pyrifol and the short external rotators. You have a question. Say that again, please.
Screws are for preventing abrasion. Basically, if it is wobbly screw, it is no screw. As good as no screw.
No, what the question he has asked is, that usually a cup provides you 3 screw holes, you know, and most surgeons will end up using 2 of them. There's very rarely that you would use all 3. If you need to use all 3, I would say actually don't use that sectoral screw cup, use a multi-hole screw cup. Because by the time your intuition and your understanding of the situation has told you that my cup is not really all that good, just using 3 screws in that sectoral part will not be enough. You need a multi-hole, if at all you have to get away with an unsymmetric. But the question he asked was, if you use 2 screws, one has got a secure sort of feel to it, whereas the other doesn't seem to be all that secure, and you don't want to go any further longer in length. Or, for that matter, the inside, the cancellous portion of your acetabulum does not have enough density irrespective of the length of the screw. I will answer your question. If your primary hold is quite good, then you might not worry too much about it. But if your primary hold is very iffy, then I would be worried definitely not worried. I would be paranoid in leaving it back only because to help you. In which case I use that third screw hold, or if required, I would change the back. To a multi-hold. So thank you.
Thank you, Dr. Ashwani, for the wonderful life surgery demo. So we come to the end of life surgery.
Recording stopped.
Thank you. Now we move on to the session 3, which is how to diagnose or failed treatment management, which is very important. So I would like to call the session directors, Dr. R.P. Meena, Dr. Patel, Dr. Ashwani Maichand, and the first talk would be trying to train the doctor.
So this surgery we have just finished, and now we'll go to the doctors who have come to our hospital for question and answer session. So we'll join you there in 5 minutes.
Done? On है.
क्योंकि आप लोग जब ओटी नहीं देखते हैं कैसे करते हैं, तो ये अच्छी अपॉर्चुनिटी थी सबके लिए कि जिसमें हम एक्चुअल सर्जरी तो नहीं, बट एटलीस्ट जो सेटअप है ओटी में, जिस तरह से टीम काम करती है, जिस तरह से वो सब अरेंजमेंट्स होते हैं, एंड ड्यूरिंग द सर्जरी जब हम डिस्टेंट प्लेस पर जहाँ पर सर्जन होते हैं जिनको हमें क्वेश्चन भी साथ साथ आंसर करने पड़ते हैं, थोड़ा सा डिफिकल्ट होता है बिकॉज वी हैव टू फोकस ऑन द सर्जरी ऑल्सो. तो बट ये रूटीनली होता रहता है बिकॉज एजुकेशन इज पार्ट ऑफ इट. हमें सब जो जूनियर सर्जन हैं हमको ट्रेन भी करना होता है साथ साथ. जो नेक्स्ट जनरेशन है उनको भी हमें अपनी जो टिप्स एंड ट्रिक्स हैं जो हम सीखते हैं, ताकि वो भी आफ्टर 10 years or 3 years so that they can also serve the community. So it's like a giving back to the community, क्योंकि हम
हो जाएगा.
So it's like we learned from someone and now we are teaching other people.
आगे लाइफ.
So lift में थोड़ा सा कनेक्शन पुअर रहेगा. Just 1 more minute.
SI joint function is a very, very common issue over there. Another problem which can lead to a failed hip would be muscle imbalance. So it is important to see that your abductors, adductors, flexors and extensors are well balanced. And before you take up the patient for surgery, so post-operatively also the problem doesn't occur. The patient gait, sitting, standing and the breathing
वॉल्यूम कम कर दो.
is not disturbed in any way. Infection, of course, I'm sure all of you are aware. I'm not going to details of that. That's not really important. Now, deficient bone ingrowth, meaning where the some of the stem breaks to osteointegrate. Once upon a time, few years ago, this was a common problem. But now, as the implants are being made better and better and better, and the surfaces are being at the center, or now we have got tantalum and all sorts of things coming inside, the problem of deficient bone ingrowth is not very common. Just one point to make over here, that a lot of times people feel that you can give zoledronic acid or you start tenibaratide to help that. How much it helps is quite questionable, and I'll not go into details of that. Number 2 is polywear.
in a hip joint, a lot of time
हाँ ठीक है सो दिस इज हाउ वी शेयर आवर एक्सपीरियंस यहाँ पर टीवी पर सारा सर्जरीज हमारी चल रही होती है और यहाँ पर इधर सब ऑडियंस है वी आर हैविंग लंच राइट नाउ और कुछ समय के बाद इनके साथ हम बैठेंगे एंड विल हैव क्वेश्चन एंड आंसर आपके भी जो क्वेरीज आई होंगी हम उन सबको एक एक करके आंसर करेंगे थैंक यू वेरी मच फॉर ज्वाइनिंग चलो हो जाए
Thank you.